the interviews. Right, so everyone should know who Marty is, but for those that are just picking up on the series, just listening now, Marty, give us a little bit of your background.
It's been a while since I've done this. I'm a sports physiotherapist working in Ireland. I work between private practice and a sports physio clinic, and then I one of the physios with the Tyrone GA team. It's the native game in Ireland, and background in Olympic sports with Ireland, the 2012, 2016 Olympics. So I worked across a number of Olympic disciplines there, working out of our institute in Belfast for about 8 years, and now kind of back home working in my own clinic and working with my sort of team that I've grown up supporting.
Awesome. So just for reference of that, if you don't know, so Tyrone, they are current champions or previous champions, aren't they?
2021 champions, yeah. So we had a brilliant season 2021 coming out of COVID, and then we had a terrible season last year. We were branded the worst ever champion.
Wow.
So we were knocked out at the earliest possible stage. So, and it's just getting interesting now. We're coming down to the latter stages of the season now. So we'll see how we've bounced back or not, as the case may be.
That'd be awesome. So the topic is for the series is the epidemic of ACL injuries in women's sport, in women's football primarily, but women's sport. What is your experience with ACL injuries, and what is your experience with ACL injuries in women?
So I was lucky enough after I qualified. I worked in the Bradford Teaching Trust in West Yorkshire, and in that trust we had a guy called Steve Bollan, Mr. Steve Bollan, who was kind of the eminent ACL surgeon at that time, doing all the Premier League ACL guys. So because he was there, he attracted an awful lot of ACL surgeons into the Bradford Trust. So we had a huge ACL program, probably one of the biggest ACL programs in England. And then we had a huge physio team as well. So like for an NHS trust, we might have had, 10, 15 ACL classes across the week. There was the morning, lunch and evening clinics. And that's kind of even unheard of now. And you're working in like a proper rehab gym. And this is back 2004, 2005. So working with ACLs now for about 20 years. So back then we were really aggressive, and we were pushing. Everybody had to be back in 6 months. If you didn't have somebody back in 6 months, you had Steve Bollan knocking on your door going, "What have you done wrong?" Because he should be good to go, or she should be good to go. So then I came home, and the private practices I've been working in since, including my own, we've always had a very strong ACL program. So in my clinic, we run probably the largest ACL program outside of Dublin. So we've probably got about 50 ACL clients at any one time. So that's everybody from you being 1 or 2 days post-op to maybe guys or girls who are 12 months post-op, are already back but come to us for some maintenance work. So we see them right the whole way through the spectrum. And so yeah, we get a lot of throughput of ACLs. So I'd like to think our team are pretty good at dealing with it. It should be our bread and butter, because we do get an awful lot. Gaelic games, we definitely get our fair share of ACLs. We have a huge physical demanding game. We cover a lot of meters, and we have multi-directional sport. So all our guys, it's like basketball, it's up and down the pitch. So we have a lot of 90 degree to 180 degree cuts, and that you can imagine then the ACL risk based on how our guys get around the pitch. So unlike rugby, you've got the contact element, but it's a pretty linear sport. It's back and forward. We have a lot more rotational work in our game over and guys and girls going at very high speeds, because our pitch is huge compared to football. So they hit max. They would hit their max speed more regularly in matches compared to, well, they would have relatively upper echelons of their max speed probably more regularly than what would happen in in a football match where it might be a recovery run from a centre back running back, trying to get a cover and tackling, run 50, 60 yards. That may happen maybe once every 10 games. Our guys are exposed to these really high speed runs a lot more regularly based on the demands of our game. So because we're hitting very high speeds, we then also have very, very high intensity decelerations in multiple directions. So you couple that with a game which, like football and globally, the female participation rate is growing massively. So we add all those things up, and it's a perfect storm for an epidemic of ACLs. And we were talking about female ACLs in particular tonight, and I was just thinking before the podcast started, when I started working in ACLs, like say in Bradford, we might have had 12 people in any class, maybe one girl in there. And whenever I started working back home here, we might have been looking after 15, 20 ACLs in the clinic I worked in first of all when I moved home back in 2006, 2007. And again, one or two girls in that ACL program. Now our girls could make up 40, 50% of our ACL class.
Yeah, what would you put that down to? Participation.
And when you look at the research, the limitation of the research is that sport's growing so fast. We didn't have enough numbers a generation ago to have really good data, because we didn't have enough playing population to draw out big common trends. But suddenly now we're starting to get that. So when you look at things like the mechanism of injuries, but also the biology behind the hormonal stuff, we're only starting to get that information now because we're getting more throughput, we're getting more girls playing, and more girls playing at a higher level and more professionalism. So the research is evolving, but it's due to the explosion of competitive female sport over the last sort of 2 generations.
That's interesting. So it's actually going to go down a little alleyway I wasn't expecting, but you mentioned that GAA has bigger pitches than football, and then rugby. So my belief is that women tend to be between 15 and 30% smaller than men. Women footballers tend to be 30% smaller than male footballers, but the pitches are the same size. So if the pitches are the same size in GAA, but the pitch is how much, 30% bigger than a football pitch?
Yeah, I would say, about 30% bigger.
So the magnitude of stress on women that come from a similar background than football in England, in that their participation is lower, their training history will be lower, and their opportunity to have a significant playing time for over years is much smaller, because there was never the opportunity until recently. That their risk is going to be, or the demands on their capacities are going to be so much higher in GAA even than in football. And in football, I think they're massive because of the extra pitch size. So what you were talking about, the opportunity for high speed running, for sprinting for men in GAA, is going to be way higher for women, because in relation to their bodies, they've got even further to go. So they're going to be playing with their hair on fire, for a bad analogy. Would that increase the risk, given that what you were saying about high intensity speed needs high intensity deceleration, which is we can talk about the mechanism for ACL tear, but it tends to be from a braking perspective. So if they're running faster for longer and more times during a game, that means they have to brake harder more times during a game. Does that increase their risk of AC, doing an ACL?
Yeah, because if you're asking somebody to run faster run longer over a bigger pitch, and the big thing, the big difference between women's Gaelic football and men's Gaelic football is they have a stadium clock that's not in control of the referee. So the fourth official stops and starts the clock. So the ball in play time for the women's game is much higher.
Wow.
So like in the men's sport, roughly about this, the same ball in time play as you would find in football. So it's probably about 45% of the time. Would that be about right?
Yeah, yeah.
Liverpool's playing some team from the draw, so probably even lower than that. But if you in women's Gaelic football, yeah, the fact that the clock is there and it stops with for any significant time out of play for an injury or things like that, the girls are having to play longer. So you add all those things up. You've got a potentially an athlete who's very high demands, but then is fatiguing. And whenever you're asking somebody who's fatigued through a very highly complex, very highly place a massive demand on the coordination, and to react then to the ball or to the opposite number, then that's the perfect storm for getting massive injuries like an ACL.
Yeah, that makes a whole ton of sense. So there's lots of discussion about reasons behind women's this epidemic, but it's not talked about. Is that when you're comparing the numbers to men, that's all well and good, but they're playing on a 30% bigger pitch. In football alone, they're playing on a 30% bigger pitch. So the physical demands on the girls are much higher than on men, even though the total distance might be covered might be less. Then it's actually kind of comparable to the WSL is kind of comparable to Premier League, but once you factor in that they're smaller, they're having to do 30% more. They're going to be constantly a higher level of fatigue, aren't they? So the actual playing cost is much higher than for men.
It is, and then you add in all the other hormonal and biological factors. These girls could be fatigued before they even start the match because of the menstrual cycle. So playing sport at that level for a female athlete is so much more difficult than it is for a male. When you take in a whole multitude of reasons, both biomechanically and hormonally. But yeah, just given the fact that the parameters, smaller athlete, bigger pitch, more time in play, those things in itself is predisposing that athlete to injury, any injury. But definitely the big injuries that are career changing and career limiting.
So would you stretch this to if we increased the pitch size of male footballers, would your fundamental belief lead you to conclude there would be an increase in injuries?
Different types. So if you increase the pitch size, you are increasing the max speed demands. Like you will hit their speeds because you're sprinting longer distances, but you will have less changes of direction, and so if you're in training, most people are aware of small sided game, medium sized games, and large sided games. So we know when we go to large sided games on a full size pitch, we hit higher speeds. But whenever we play 5-a-side on a small pitch, we don't hit anywhere near the same speeds, but we have much more decelerations and changes of direction. So you make the pitch bigger, you get them to run at faster speeds, but you're probably going to reduce the amount of change of direction on that size of pitch as well. So you're robbing Peter to pay Paul. It's not just as easy as saying bigger pitch, more injuries. Whenever you manipulate the amount of players on any size of playing pitch, you're changing the parameters sometimes in a good way and sometimes in a negative way in terms of increasing.
But you're probably going to increase the fatigue.
Well, you're definitely going to increase the fatigue.
Right, yeah. That makes sense. And it's definitely something I've never really thought about. Can you talk us through quickly the mechanisms of injury, but then give us the three things that you believe are women's biggest risk factors right now in women's football in England.
Okay. So the mechanisms of injury, you want that first?
Yeah.
So the mechanism of injury is always going to be a deceleration. That could be a deceleration in a number of ways. So if you imagine you're sprinting up to a certain point and you stop and you change direction and you come back the way you just ran, that's a 180-degree cut. So you've changed direction 180 degrees. If you do that, or even you increase that to say a 210-degree cut, where you've run up to the point you've cut, not just turned back on yourself, but you've turned back on yourself to maybe 30 degrees more. So if you imagine you're running from the center circle right to the edge of the box, right down the middle of the pitch, but you stop and then you run and cut back out towards the wing. So that's like a more than a 180-degree cut. Doing things like that with those high angles, that's a significantly more dangerous change of direction than say you just go up and curve your run maybe 20-30 degrees. So but every time you change a direction, there's usually some form of deceleration. So but the higher the angle you change direction, the more likely you are to suffer an injury. So the big one, the most common time we see somebody tear their ACL is whenever they have changed direction between 90 and 180-degree cut. So they've gone up and they've broke left or right, or they've gone up and they've come back on themselves. And what happens in that circumstance is that they lose lumbopelvic control, so the ability to control their core and their pelvis and hold them in optimal positions. That usually leads their pelvis to drop on one side, their hip to internally rotate, that causes their knee to rotate inwards, and it puts what we call a valgus strain in their knee joint. So that means that their foot is turned out, but their knee is rolled in, and in that mechanism, that puts a huge strain on the muscles around the knee and the muscles around the hip and the muscles around the foot and ankle to be able to control that knee joint. And if that moment happens too fast with too much force, and your muscles can't react quick enough and strong enough to prevent that knee rolling in, the knee rolls so far in, then an injury, a soft tissue injury, will occur at the knee. And one of those, and the most extreme of those, being you will tear your ACL. So that can be accompanied by tearing of the MCL, tearing of the meniscus or the cartilage in the knee. But the big one in terms of severity is whenever that happens to the extreme and they tear their ACL. So, for the older listeners, that's the mechanism that Michael Owen did at the Euros whenever he done his ACL. That's a really famous one where he's gone, tried to change direction 180 degrees, and his knee has rolled in, forced valgus, and bang, then he's torn his cruciate. Some other mechanisms then is, from a jumping and landing perspective, if you can't control the landing and you land on one leg more so than the other, or you land with all your weight on one leg, and you can't control the load and weight of your trunk on your pelvis, then that shift at your pelvis again can cause your knee to fall inwards, and that knee falling inwards can then tear your cruciate. The other mechanism then from a jumping and landing moment is whenever you land on a knee and your trunk falls forward and your knee is hyperextended backwards, and that would be the Zlatan's ACL mechanism for whenever he was at Man United, and his knee folds backwards in the wrong direction. Most ACLs that we see is the predominant one is that change of direction. So you're running linearly, you change direction between 90 and 180 degrees, your knee rolls in and you tear your cruciate. You jump and land on one knee and your knee gives in, or you jump and land, you make it a nudge in the air, but something happens that you can't optimally land that jump and your knee folds in. And then the third one is something happens, you're trying to decelerate, either landing or decelerating from running in a linear fashion, and you can't control it at your trunk, and your knee flex back and you hyperextend your knee and tear your cruciate. So those would be the big three, but the first one to describe would definitely be the most common.
Yeah, that makes a lot of sense, and you tell me stuff I don't know all the time, and I know about this stuff, so it's always fascinating.
You have as much experience this year as me.
Yeah. So actually, instead of you talking about potential causes for this stuff, right? Can you talk me through specifics of physiotherapy for this? So, like, first of all, what would be the immediate response from a physio once you see the potential of this having occurred on a pitch in real time?
If you see the potential of this happen on the pitch, the first thing to do is remove the player from the pitch. And you would be surprised how many times a player is left on the pitch after they've done their ACL, especially if it's their second ACL, because we'll talk about it in a bit, but whenever you have your ACL reconstructed, it's reconstructed with using your hamstring and groin tendons or your patella tendon. But it's not a real ligament in there. It's harvested from other tendons. So whenever you have the second one, whenever you tear it, it doesn't have the same pain, doesn't have the same swelling, doesn't have the same signs and symptoms afterwards. So you just feel your knees moved, and you could get up and shake it off and go, well, I'll try to play on. But then the next time you go to turn, because your cruciate's not there, you're down again.
And it feels weird. Is the thing I've heard a lot. It just feels weird.
Yeah. So, but if this is the first time when we're talking about, the main thing is to move, be able to recognize the mechanism of injury and the potential severity of the injury, and to act in the best interest of that player and to remove that player from the pitch. The majority of the time, that's a really simple decision to make, because the player's in agony and they've had really severe pain, and it's a fairly you're not going to be trying to get some free spray or some water on that knee and try to get the player back on. Most people know that they're going to have to come off. So you've successfully removed the player from the pitch, and then it's about managing the signs and symptoms. So that might be some pain relief. It could be splinting, crutches. Allowing that person to get to the hospitals. You want to get with those mechanisms of injuries. There's always a chance of a fracture, and so you want to get that injury x-rayed and manage and make sure that that's dealt with. The vast majority of the time, there's not a fracture there, but we are seeing an increase in trend of more tibial plateau fractures with ACL injuries. Maybe that's the guys are bigger and stronger, they're twisting and turning with more force, but we are seeing more bony injuries along with the other thing is that the MRI scanners are better now and more sensitive, and we're picking up these fractures more. But that's a trend that we're seeing more bony injuries. So you want to make sure that the person's being x-rayed. Then you're sending them home. They're staying off their feet. They're maybe on crutches. You might then see them, if it's a professional setting, you might see them in the training ground a couple of days later, or you're seeing them in clinic a couple of days later. And at that point, when things have settled, you're doing some orthopedic testing that test out your hypotheses that this person potentially, severed their cruciate. There's some really clear clinical tests that you do that have very high specificity and sensitivity. So when you've done them, you pretty much know that this person has done their cruciate, but you would get an MRI scan to confirm that diagnosis. So most sports physios.
I was going to say, can I quickly jump in there? Have you noticed any difference when you're doing the clinical tests, the ones that are very obvious? So from what my experience would be, over 85%. If it looks like a positive ACL tear, it's a positive ACL tear through laxity in the knee, whatever. Do you see a difference in those ratios for men and women? Is it less accurate with women?
I would say it's probably more accurate for women, because the In my experience, if you're dealing with a very large male player, they can have really massive hamstring tone. And so whenever you go to lift the tibia and pull it forward to test the ACL, the hamstrings can kick in and pull back against you, and then you can't get a good enough test on it. But we could have some girls with brilliant hamstrings and professional female rugby players and such, but it tends to be the really big male players that you struggle with, and not so much the females. But the Lachlan's pretty conclusive. Then you're sending for an MRI, but they are the ones where they've partially torn their cruciate, and you know that they've done something, but you still feel an end field. Still something's there, but you want to know, is there enough there? It's going to be robust enough to allow this person to go back to sport. So you get the MRI scan from there. They're sent on to the surgeon to probably, if they're at a high level of sport, they're going to need to be able to have that surgery to be able to return to sport. The physios are not split, but there's probably a minority within sports medicine and physio that believe that you can rehab somebody successfully to get back to high level sport in a pivoting sport like football or any football variation, be that rugby.
I literally just wrote that down as a question.
But I have never seen any evidence of anybody being able to do that long term and do that successfully. And there's a paper published last year, but when you dig into what the actual success rate of that was and how long these people lasted, it wouldn't leave you as optimistic as the headlights would have you believe. So anybody I work with goes for surgery. I don't think I wouldn't take a chance with anybody's career and say, like, let's rehab this for X amount of months and hope for the best. When it's difficult enough to get back from surgery, but the chances of you making it back to high level sport after surgery are much better than taking a chance with conservative management. And careers are so short, they wouldn't be taking a risk on it.
Couple of quick things here.
So,
go on.
But I said, during that whole time where you're taking the person from diagnosis right through to boarding them for surgery, as soon as it's physically possible, you're getting that limb as strong as you possibly can. Because as soon as the injury has occurred, they've got pain, they've got swelling, the muscle will deteriorate. They will start to lose quadricep bulk very, very quickly. Your quads don't like working in the presence of pain or swelling, and you're going to get a lot of pain and a lot of swelling with an ACL injury. So you need to keep that muscle on as in any way you can. So you might use neuromuscular stimulation. So most people have seen that with Ronaldo advertising the six-pack abs where he gets electrodes on his abs. But what they're really used for is stimulating your quads, calves, hamstrings after an injury like this. Once the knee is settled down and it isn't as painful, isn't as swollen, you're getting the person back into the gym and you're trying to pack on as much muscle and as much strength as you can before they go for surgery. And even at the top clubs in the world, these guys aren't going for surgery immediately unless it's an emergency. So what the surgeon will want is 4 to 6 weeks probably of letting this knee settle down, because if you try to go in and do surgery on a really acute knee who's had this trauma, and I've seen it whenever they put the keyhole camera in, it just looks like you're trying to operate in a blizzard, because the fluid in the joint is so inflamed, it looks like snow in there. And if this is a career-changing injury and your career is in the hands of the surgeon, you want him to have a really clear picture on that screen whenever he's doing that. And then there can be so many complications from that information. Your knee can get really stiff, really sore, get a lot of scar tissue. So people are always asking me, can I get the surgery, next week? And you don't want it next week. It's not good for you. So usually it's a month down the line, you let that knee settle and you have that. It's only whenever you've maybe done your MCL, your ACL, you've done 2-3 ligaments and your knees hanging together, that's when you would have surgery a wee bit sooner, potentially. But usually now we brace them, we put a splint on their knee and try to get everything else to heal up a wee bit better and then do the ACL down the line. So it's a very busy period. It's kind of non-stop. From you've had that injury on the pitch, it's trying to work as hard as possible to get the pain and the swelling down in that immediate few days, to then getting them back into the gym and getting them as big and strong as possible, because you're going to lose muscle after the injury, but you're also going to lose muscle after the surgery. So you're just trying to negate the negative effects, after the surgery, to pack on as much muscle beforehand, because you're going to lose some of it in the immediate aftermath of the operation. So it's a very, very busy period before you even start the proper rehab journey on the other end.
Makes a ton of sense. Do you see, without working in women's football, you probably don't get this much insight, but a difference between, so those things are really important, right? So getting treatment straight away, getting a diagnosis early, a high quality diagnosis, and then a plan of surgery, but then also starting rehab straight away before the surgery. You can get that as well.
1 second. I'm working. I got you there. No, I'm working. I'll call you later. I'm on a call. See you soon.
Bless it. Yeah, that's fine. So the prevalence of high quality medical support is going to be important. It's going to play a factor in how a girl recovers from this, and the likelihood of am I right in thinking the likelihood of a recurrence? Because they're already quite likely. Once you tear one, you already increase your risk by how much within the next 18 months of a tear?
It depends on the type of surgery, and it depends on your age. So if you're a very mature athlete, and you've had thousands of minutes of football under your belt, and you've had an ACL for the first time ever at 30 years of age, you imagine how many decelerations you've had in your career, and you've been able to withstand those, then this is probably a freak occurrence. If you're a 16-year-old, you've had no training playing load, and you do it at 16, your recurrence rate is massively different because you haven't any time under your belt. So you probably have a lot of biomechanical or hormonal issues that are affecting you that maybe isn't affecting the 30-year-old in your team who's never been injured but has had a contact ACL down the line. So it depends. Is the answer, but you're really susceptible to having a reoccurrence either on the affected leg and on the unaffected leg, because for a number of reasons. Again, it could be genetics, could be the shape and anatomy of the bones in your knee, it could be the thickness of your ACL, it could be the angle at which your ACL goes in, it could be how much collagen is in your tissue, so that's the scaffolding that makes us all. So it could be any one of those genetic factors that is causing you to be more at risk or not. So if you've had an ACL injury in the early stages of your career, so I'm talking under 21, and you want to play a full career right through to your 30, it would be almost impossible for you to get through the rest of your career not doing all, either on the same side or opposite side. You'd be almost guaranteed. You'd have to have a lot of luck going for you, and you'd have to do a serious amount of work, and you'd have to be surrounded by a really good team.
I've had girls on their third ACL in before they were 21.
Yeah, unfortunately, we just have a lad, really talented player, and he's had his third before he's 21, and the surgeons had to tell him that that's it, it's not worth it. But I think I have had somebody who done 3 ACLs by the time he was 19. I took up MMA, and now he's Cage Warriors world champion, and is going to UFC.
That's crazy.
Going to UFC.
That is great.
But you think change of sport from Gaelic football to MMA would be more injurious? But he's able to operate at that.
That is crazy. So, but that actually, by going off another tangent, that is that there are unique challenges to ACLs from field sports, from chaos-based field sports than kickboxing. It's just different, and one has a greater risk of one type of injury, one has a greater risk of another type of injury. That's all. But with staying in field sports with women, one of the things I was trying to get down to really is the quality of medical provision available to men versus women. So does that matter? Would that matter from an injury diagnosis perspective in relation to how well that player recovers, but would it also matter for two other reasons? Can other injuries increase? So if you've got a history of other injuries, is there anything that can increase your likelihood? No, not likelihood. Increase the risk, the chances of you getting ACLs further down the line, and is higher quality medical physio advice, but then also going down into a training plan advice, could that before you tear ACL reduce your risks of that? Because boys get that stuff from an early age. There's a pitch side physio with 9-year-old academy boys, and there's no pitch side physio with first team women outside of the WSL.
Yeah, and so first of all, the quality of your medical and science team around you is hugely important. So if you take the science element, first of all, if you don't have a sports science S&C team who can plan your training load across a year, that's potentially going to leave you either under strength or underloaded, and then when you're not physically ready for the demands of your game, and you're not strong enough to do those decelerations. Maybe your BMI is too high, you're not strong enough. Could be a whole host of reasons that leaving that athlete predisposed to injury. So if you have an inexperienced or underskilled science team, then that's really predisposing that. And in Gaelic games, I can say that the medical teams I know from our women's teams are really good. But if you take them on a case-by-case basis, compare them to the men's team, they don't have the same experience. They're brilliant, but they, on average, they're a lot less experienced, but they're still very, very good at what to do. But that's the reality of it. And a lot of the women's teams are catered for by new grads, and they might not have many. The very top teams might have sports science. Half of them might have S&C. The physios will a lot of times be 1 or 2 or 3 years qualified. You take then our men's team, we 4 physios. They're all 10 years plus qualified. They've all got a huge experience in sport. We've got 2 doctors with decades in sport, and with 2 masseurs, and we have an S&C coach who's working on professional rugby. So we're really well stocked. And most of the big teams will have that, but the women's team won't have a quarter of that, but the staff are I don't want people on the staff are brilliant, but it's not like for like yet, but it's getting there and it's moving in the right direction. But that having that support team doesn't guarantee you that you're not going to get an ACL injury, but it definitely helps, because on your next point, there are other injuries that can predispose you. Yeah, there is. Like if you have weak hamstrings, if you have a history of hamstring tears, that's going to massively affect your ability to decelerate. If you have, rec fem, quad injuries that hasn't been rehabilitated, calf injuries haven't been rehabilitated, that's all going to affect your ability to be able to absorb those deceleration forces. If you've had a previous hip and groin or an ankle issue, can you transfer weight in the frontal plane, so from side to side appropriately? A really good physio and a good S&C team are going to work together to make sure that you rehab from your old injury maximally to help try to prevent the next injury, because you've only so much slack in your system and everything's connected, and we found with our team that almost everybody in our team over the last 3 years who's had chronic hip and groin pain have all had chronic ankle instability 2-3 years previous. And the ankle's the one where, we've rolled it, we'll get them back in a couple of weeks, we'll strap them up and we'll finish out the season. Then you come back the next season, you've all stuff to worry about. But that ankle's still always a bit unstable, so they're not changing direction appropriately, and they're not loading that hip appropriately. And then the next thing they break down with chronic groin pain. And so that's just the link between ankles and groins. But there's so much evidence out there on the effect of calves and groins, calves and knees, calves and hamstrings. Everything's linked. And if your medical team and your science team aren't good enough to be able to identify those old injury factors and treat those to the best of their ability, then you're going to predispose yourself to other injuries like an ACL. And now I forgot your third point.
Me too. That is everything that I was. I think I was laying out, but it's definitely down the pathway that I'd been considering. The way football works, and mostly all sports, is that the grad sports science, the grad physio, the grad sports therapist, whatever, they start out in traditionally. When we're talking traditionally here, sports science has really been only in football for 10 or 15 years. They traditionally would, if the club could afford it, get you on a part-time hours working with the youngest kids. And then over your experience next year, you might get promoted to some older kids, up until the most experienced people work with the men's first team. And so you're always getting the inexperienced people working with it's a bugbear of mine anyway, but of a different reason, but always working with the younger players. But that has been replaced in the last 3 years with, underneath the working with 6-year-olds is women. So it's easy to get a part-time job in women's football. And so you're working with the least experienced S&Cs, the least experienced. You don't even get physios in women's football outside of the top 6 of the WSL. It's sports therapists. You're getting graduate sports therapists and even undergraduate sports therapists that are working as the pitch side physio with the first team of pretty much every team outside of the top 6 in the WSL, but definitely tier 2 downwards. They are graduate or undergraduate sports therapists. Having that inexperience leads them, in my experience, to see. We've had conversations about some of my girls before that get sent to the physio and get diagnosed with, she's got a torn ACL, she's got a broken leg, she needs to go to the hospital, when both of them just had abrasions. And conversely, I've seen an ACL tear get diagnosed as a pulled calf. And there's only so much blame you can attribute to these practitioners, young practitioners, but an issue for women's sport, in my opinion, is that they're getting the youngest, least experienced versions of these very highly skilled positions. So that's an added layer to all of these other things that supposedly are causing injuries.
And we've heard Hoddy Roach and Des Ryan speak many times about, you should, if you're getting to work in academy football, you shouldn't see it as a stepping stone as a first team. That should be your career choice. I want to be the best youth coach I can be, and this is my dream job. This isn't a stepping stone. And I've been there. I was 2004 working for Huddersfield Town, and I was just graduated, and I was the only physio in the academy. And we were in administration, and I'm just out, and I have nobody to tell ask for advice. But so it is the least experienced people doing these jobs. I know, as you say, you've got women underneath that, but women in sport and women's ACLs and everything to do with is such a specialized area that needs to be a career path of its own. We need physios who want to see, my dream job is working as the head physio at a WSL team or the ladies inter-county team. They don't want to see it. If I get in there, I'll maybe get in with the under 18 boys, and then I'll get in with the first team.
Because that is the journey for people that don't understand. That is the journey. You can get to work for Man United women, and then it might get you a job working for Aston Villa's under 18s.
Yeah, but then we need to pay these positions well enough that that you see this as lucrative enough. This could be your dream job. But the stuff, how to prevent ACLs in women's sport is so complicated that these new graduates that are working in these positions, they need support from very experienced practitioners to be able to do their job effectively. This stuff is not easy, and we haven't it's for a different podcast talking about the hormonal factors. But you need to have a full grasp of that. Like, how many new grad S&Cs working in women's football could tell you anything about the menstrual cycle, or the fact it has in sport or training or predisposition to injury?
Or you had to go a layer above that. How many grad S&Cs, which are predominantly male, but even the girls, how many of them feel comfortable enough around girl footballers, teenage girl footballers, to have the conversation in the first place, even if they know all about it? How many? I've sat in rooms with these coaches, and they're like, girls don't talk about it. I'm like, well, actually, girls talk about it to me all the time, and I'm old. I'm an old bald dude. Like, it's a level of coaching, but it comes from a level of confidence you have from being good at your job for a long period of time.
Yeah, and my physio patients talk about it to me all the time. Other end of the spectrum, I've got patients coming in, they're talking about their perimenopausal and menopausal symptoms, but they weren't talking to me about that when I was 21, and I was just like, I run a mile, so you need to have experienced people in these roles, but you need to pay well enough to get experienced people into these roles, because this is very difficult stuff, and it's so much easier for a woman, for the reasons we've described, to have an ACL injury. And we've got some figures in our sport, is it's so much harder to get back from. When a woman has an ACL injury, their chances of getting back are I think in our sport, it's 5 times more difficult to get back to the highest level than it is for a male. And there's issues there around our medical insurance, loss of earnings, because we're in an amateur sport, so these guys have full-time jobs, and they don't have the support that maybe our male players have, because there's been examples of our male players doing an ACL, and some of the teams will just say to their employer, how much will it cost you for us to replace that person in that job for the next 9 months so he can come and rehab full-time as a pro? That never happened in female sport. That's just not going to happen. But it has happened in male sport. And so there's a lot more support, unfortunately, placed around our male players than our female players, and it makes it much more difficult, much easier for them to get the injury, and much harder for them to get back from injury.
Perfect.
For a whole injury the anatomy.
That's pretty much what I wanted to talk to you about. You nailed it perfectly. We could really talk about this for the next 6 hours, going down hormone, nutrition, training history, the biomechanics of it all. But there is, without doubt, a support deficit around women's sport in comparison to men's. And does the support play a role in injury prevention as well as performance? I certainly believe so, and it seems to me very much that you do too.
Yeah, totally. And the thing about our sport is, at the minute, we're totally separate organizations. We play in the same places, we train in the same places, but the actual governing bodies are separate. And we're at this point minute where we're merging, and we're going through an amalgamation phase. And that's very, very difficult. You have the people in the top jobs, and there's only one top job, and at the minute we have 4 people in 4 different organizations, or three people in 3 different organizations. So nobody wants to give an inch, but when that amalgamation happens, hopefully the good things that the men get will be there for the women, and that goes in terms of service provision, both and also support, financial support, social support, everything else that goes with it. You imagine you're the best player in the male team, everybody wants to help. Everybody wants to help you get back, and unfortunately, it's just not there for female athletes.
A simple example from that is our best. I'm talking our ambiguously here, but our best player in the first team, she had heart issue last year in April, and she got there was nobody at the club. She didn't get any diagnosis from club doctors, or any discussions with club doctors, any support other than the sports therapist, and kind of The manager touched base with her. She was kind of allowed to come around a little bit, but basically everyone was so scared that she was going to have a heart attack because she had a heart problem without understanding what it was. And it took from April last year to April this year for the NHS to go, oh no, she's fine. And by which stage the club have decided that she can't play this year at all. So just come back for next season. And she's literally the women's best player. And that's how little support any of our players get.
Yeah. But you tell that same story, but that's the male player at your club, the best player in the club. That's sorted out in a couple of weeks.
Yeah, 100%. Yeah, they have an echo. They'll have an MRI if necessary, and it'll all be done within 2 weeks. And
the lucky thing
they just get into the NHS, and weirdly, there's a weird. I don't know how much experience that you would have in this, but in my experience, if you go to the A&E in a football kit, there instantly it gets their back up. You get further down the waiting list, and if it's weird. If you're a female in a football kit, they almost have this stain. And I went through this 19 times this season, and it takes forever. And it all depends on who is on the A&E counter of how quick, whether you get in within the first half an hour. One of my players got ACL surgery in 4 days because she got her X-ray at the A&E. The consultant walked past, saw her in a Derby kit, was a Derby fan, and he booked her in and gave her ACL surgery in 4 days. And then I have others that are sat waiting 20 hours for an X-ray on wrist.
That's mad. Well, the one thing we're lucky with is that all of our players have, I think it's a €5,000 budget. So whether it's Camogie, which is our the female version of hurling, men's football and hurling, or ladies Gaelic football. If you get injured in any of those sports, your physio, your MRI is covered, your operation is covered up to €5,000. So if you have an injury, there's a medical fund there that will pay out and sort all that out. You just need to get yourself in front of the right physio or the right doctor to have it all clearly packed out. So we don't have our top players, even at a club level, at a local club level. Our players aren't waiting on the NHS. They all go privately because the money's there. But that's the payoff for not being a professional sport. So our guys don't get a couple of £100 a week to play the game. But if anything's needed medically, it's covered. So that's the difference. We don't have those same issues with A&E and having to wait on the NHS or having to wait NHS for cardiac investigations. That would all be dealt with.
Makes a ton of sense.
And the women are looked after as well as the men in that regard. But it's more the loss of earnings and the support and all that, the social end that goes with it, because we see it. That the women's out for 9 months. They can definitely fall out of that social circle and not have that same support structures that the men do. It ends up making it more difficult to hang in there for this really slow, laborious, boring rehab process that's going to need to get them back to the highest level.
It's interesting you mentioned that, because I want to wrap up because I've taken way too much of your time and we did the stuff that I wanted to talk about. But without coming off as sexist, which will be impossible, my experience of coaching men and women is very different, and the girls I've experienced tend to be much more social animals. They work better as a group. They enjoy being part of the group. They like to stand out from the group as little as possible. They care for one another. And then one of them's injured, gets taken out of it. They aren't swarming around those because they're still busy doing their stuff, because they still have loads of stuff to do. And that girl gets left on her own. And there's no forum for them to come into the club for treatment. So they're just not in the club. For weeks or months on end, people might check in on WhatsApp groups, but it's not the same as being around. And in the men's version of the sport, they're literally in the train. they still get depressed from being isolated, but they're in the training ground with everybody else. It's a very different environment.
Yeah. We had a player who massive hamstring tear, needed surgery in London, and but as soon as that happens, as soon as the word gets out that happens, a very high profile player, but you have business people coming, is that being covered? Do you need any money to have that surgery? Does he need people offering to drive him to the airport to take for his flight to London? It's all that stuff that does not happen for our female players.
Wow.
It's a different world, unfortunately. But hopefully, things are changing. If we had this podcast 5 years ago, 10 years ago, the situation would be even worse.
Well, we wouldn't have had this podcast 5 years ago, which is what says it says everything about how women's sports changed in the last 5 years.
Yeah, that's true.
Awesome. Dude, I really, really appreciate your time. Thank you so much for that.
Thank you. Always a pleasure.
Is there any place that people can contact you if they want to annoy you with advice and with asking for questions and advice?
Yeah, Twitter is probably the best place. I think it's Marty Loughran 83 on Twitter. That's probably the best place to get me. You can get the links to the clinic and everything from there.
I will put all of the links on the pod when it gets published. Thanks again, dude.
Okay. And look, I just want to say I'm piggybacking